So with this, I think we go to the Tribate. I'd like to invite Dr. Rajiv Passey, Dr. Naveen, and Dr. Mani, please. Yeah.
Thank you, Dr. Rakesh Gupta, for having me here. It's a pleasure to be among the top physicians of North Delhi. And
Dr. Rajiv Passey, father, was my teacher along with Dr. M.D. Gupta. I always remember him. He was an absolute fine man who guided many people in this part of our Delhi, especially North, and all around the world. And whenever they came to Hindora Hospital, he was always helpful to all of them. And that's what has transformed into Dr. Rajiv Passey, leading cardiologist at Gangaram Hospital. I can proud to say that at one time I was helping in his echo thesis. I still remember in Shamla Nursing Home. That's what Dr. Rajiv.
Yeah, I'm always grateful to Dr. Rakesh Gupta for that. And that is why today I like to there is a very important aspect of coronary artery disease, which is medical management. And as intervention cardiologists, we tend to ignore it, or we tend to think that this is a subsidiary of the intervention. But over the past few years, with availability of newer drugs, one. Second, we had a very robust trial, the ischemia trial, which told us that there is a definite role of medical management, especially in chronic coronary artery disease. So I'll just illustrate that CAD we know is because of narrowing of arteries, because of deposit. This CAD can be divided into chronic coronary syndrome, acute coronary syndrome, unstable angina, non-STMI. STMI, the patient can develop ischemic cardiomyopathy, giving rise to heart failure, and then finally sudden cardiac death. So chronic coronary syndrome are the ones which are most important for medical management of coronary artery disease. We have lifestyle and risk factor modification, disease modification, and in some patients, revascularization is essential. It is important to realize and to bring out which are those patients who will benefit by revascularization. So this is what the basis of my talk in the next few minutes. The therapies to reduce CV events are very important. The first and foremost, which is the most ignored, is the lifestyle and risk factor modification. This includes smoking, substance abuse, obesity, which has now become a very important and hot topic with the availability of drugs, hyperlipidemia, the most ignored part of coronary artery disease, but possibly the most treatable, diabetes, to keep the HbA1c less than 7, control blood pressure, diet and alcohol consumption. Alcohol is documented now that in whatever quantity you take, it is harmful. To increase physical activity and exercise, this is also has been a controversial topic, but by and large, it is well accepted that we have to have at least 30 to 60 minutes of moderate exercise more than 5 days a week. The last, which is not written here, is stress. So stress, we all know, is a contributor to chronic coronary syndromes, to acute coronary syndrome. So reduction of stress is also very important. Now, over the past few years, we have developed some newer drugs, some newer thought processes like SGLT2 inhibitors and GLP receptor agonists, which are very important from risk factor modification. But in the future, we can foresee that they will be a part of coronary artery disease management, because these are the drugs which have clearly shown CV benefits when they are given in appropriate doses. The lipid lowering therapy, we have the last year we got the CSI guidelines. So India is blessed to have the lipid guidelines which came and which has given us very clear directives. Dr. Sahni, our chief at Gangaram Hospital, was the person who was instrumental in getting these guidelines. The guidelines clearly indicate that we have to maintain an LDL less than 55 in patients who have significant coronary artery disease. It should be less than 40 in patients who have had repeated events. These guidelines are extensive, and this is not the platform to discuss them. But I would like to emphasize, now we have, beyond statins, so many drugs, so many modalities available that we can achieve the goal that we need to do. The next important aspect of coronary artery disease is the antithrombotic therapy. Antithrombotic therapy includes antiplatelets and antithrombin therapies, and thrombus formation, prevention of thrombus formation. So this includes the P2Y12 inhibitors, the GP2B3A inhibitors, the thrombin inhibitors, as well as thromboxane inhibitor aspirin. So all these have been used, and I would like to illustrate some examples. We know antiplatelet therapy is an important part of management of chronic coronary artery disease in all patients for life. The 24 European guidelines clearly state that aspirin or, and as a second choice, clopidogrel are safe and effective alternatives. And after CABG, as I'm sure Sir will elaborate in the next few slides, aspirin should be continued lifelong. And even in patients who have had coronary artery disease without revascularization, aspirin should be continued lifelong. Now, the newer concept which has emerged is the role of DOACs in chronic coronary syndrome. COMPASS was a trial which clearly indicated that patients with either risk factors or established coronary artery disease in more than one vascular beds were those who benefited by a combination of rivaroxaban in low dose with aspirin as compared to rivaroxaban in a higher dose or aspirin alone. So this clearly indicated that the net clinical benefit of rivaroxaban and aspirin over aspirin in chronic coronary syndromes was significant. So now the recommendations are that we can give rivaroxaban in low dose in patients of chronic coronary artery disease who require long-term therapy. The major bleeding is less. The major bleeding, or life-threatening bleeding is not significantly different, but the net clinical benefit is quite significant. So now it's a two-way recommendation to add a second antithrombotic agent to aspirin for extended long-term secondary prevention should be considered in patients at enhanced ischemic risk and without high bleeding risk. So anti-inflammatory therapy, again, this has been in chronic coronary syndrome. This is now a well-established fact. Colchicine in low dose should be considered to reduce MI, stroke, and need for revascularization as a 2A guideline. Anti-anginal therapy, the traditional nitrates, beta blockers, calcium channel blockers, trimetazidine, ranolazine, ivabradine, we have all been using them for decades now. They all have a role as far as coronary artery disease management is concerned, both to improve prognosis and to reduce symptoms. So it is important that if the patient has AV blocks, the patient has bronchial asthma or COPD, that we avoid beta blockers. So a combination of these, and all physicians are well aware that which is the best medicine to be used in which scenario, and these have been traditionally used and we should be continuing to use them. So what are the indications of revascularization? I'm sure Naveen will bring them out in the next few slides. We have to have a functionally significant left main stenosis, functionally significant triple vessel disease, particularly if proximal LAD is involved, an ischemic cardiomyopathy, LV dysfunction of ejection fraction less than 35%, a patient with refractory angina. All these are patients who benefit by revascularization. So acute coronary syndrome, the goal is totally different. In this, we have to control cardiac pain. We have to identify patients with for reperfusion. We have to make sure that even the low risk factors we do not miss out. As Dr. Manish Bansal had pointed out, patients with normal ECG but with RWMA on echo needed revascularization. So it is very important that acute coronary syndromes should not be missed. The ACS presentation, we have to realize, is initial ACS assessment, ECG, physical examination, history, as well as troponin levels, ST elevation MI, immediate angioplasty. Fortunately, the acceptance is increasing. The number of people undergoing angioplasty is increasing, primary angioplasty, and this is definitely resulting in saving more lives. Non-ST elevation, if there is a high risk of MI, immediate angiography and PCI should be considered. Non-ST elevation without high risk, within 24 hours, the angiography should be
you'll have to
performed.
wrap up your talk.
Yeah. So, as I mentioned, the various factors to control, which includes BP, LDL cholesterol, control HbA1c. Anti-thrombotic therapy beyond 12 months, it is important to realize that whether aspirin, rivaroxaban with aspirin, or two P2Y2 inhibitors in patients with high ischemia burden and low bleeding risk. If the bleeding risk is high, we will probably have to shift to a single antiplatelet agent. So this is what my summary of my talk on medical management today. In chronic coronary syndromes, therapies for preventing CV events are most important now. See, it is not just symptomatic relief. We have to give, so that is how I illustrated that we have newer molecules which are coming up, which in the future would probably be instrumental in improving the prognosis of patients with chronic coronary syndrome, which includes lifestyle risk management, SGLT2, GLP analogs, appropriate reduction of LDL cholesterol, antithrombotic therapies, low dose colchicine, revascularization wherever it is indicated. And ACS, of course, reperfusion is by far still the preferred modality of treatment. I thank you all for your kind attention.
Thank you. I think we'll go for the next talk by Dr. Naveen. We'll have the question answer session after the third talk. Yeah.
Good morning, everyone. Thank you, Dr. Rakesh, for inviting me for this debate on CAD management in 2025. Good morning, all the chairperson and panelists. CAD management की बात करूँगा 2025 में, तो अगर हम स्टार्ट करते हैं, एक फैमिली ड्रामे की तरह है, जिसमें मेडिकल मैनेजमेंट जो है वो बड़े पापा हैं, सर्जिकल मैनेजमेंट ठाकुर साहब हैं, और इंटरवेंशन जो है वो घर का वो वाला बच्चा है जो टैक्स हैवी है, जो AI बेस्ड है। वो कहता है मेरे पास आओ, 1 घंटे में ट्रीटमेंट कराओ, घर जाओ, नेक्स्ट डे आप घर जाओ. सो जोक्स अपार्ट, वी हैव मूव्ड in the management of CAD from the Courage trial in 2007 to Syntax trial in 2010 and Ischemia trial in 2019 and other trials like Excel and Noble trial. And every trial, हर trial ने हमें कुछ नया बताया है how to manage the CAD. Medical management is the foundation. Surgical management is for the multi-vessel diffuse coronary artery disease, but intervention is, precise. I can say it improves your quality of life. It gives you a rapid recovery. So intervention is the requirement of today. If we see in this trial, in this slide, in the 1990s, medical therapy was the best way to manage the coronary artery disease as compared to surgery, because surgery was only for the limited patients available that time. In 2000, surgical management dominated, because surgical management is for the management of diffuse coronary artery disease, for the complex coronary artery disease, and PCI at that time was not much modernized. But in 2025, the PCI is precise, is safe, with a rapid recovery. So it's patient-centric, anatomy-specific is very important. आज भी in 2025, CAD is the #1 killer in India. The scenario is, father is bringing his son for the management of coronary artery disease, which was not there in 2000s. So every hour we lose young lives, fathers, mothers, CEOs, students gone. Medical therapy slows the disease, surgery delays it, but PCI solves it right now. That is why I am here today, to make a case that it's not just a scientific, it's personal, it's urgent. There is no debate in the management of acute coronary artery disease. In ACS, in acute ST elevation MI, primary PCI is a class 1 recommendation. CABG is not feasible in most of the acute coronary syndrome cases, and OMT does not restore the blood flow to the culprit artery. And if you talk about the non-STEMI or unstable angina, early invasive strategy reduce the reinfarction, mortality, and prevents the myocardium. What makes PCI unbeatable is radial access, rapid loading, high volume centers. The real debate starts in the chronic CAD. Ischemia trial, OMT is enough. Ischemia, but ischemia excludes the left main disease, triple vessel, severe symptoms, and the real world angina patients we treat daily. What patient want? It's not just the survival, it wants the quality of life, and they want relief, return to work, and freedom from angina. The FAME2 trial has clearly shown that OMT plus PCI is often what gets them here, because when pill fails, balloon delivers. And sometimes stents are the answer. So physiology guided PCI avoid unnecessary stenting of FFR negative regions, and something CABG cannot skip. Why PCI wins? PCI in 2025 is not PCI in 2005. There are stents which are thin strut, biodegradable polymers, ultra thin disc. Imaging, physiology, FFR guided imaging, FFR guided physiological imaging, IVUS, OCT for the precision sizing optimization. Drug coated balloons for the small vessel disease, instant restenosis, and high bleeding risk patients to allow the short GAPT for 1 to 3 months. We have a calcium modification tools available in the form of rotablation, orbital atherectomy, IVL. So no lesion is too tough now for the cardiologist. Mechanical circulatory support, with the availability of the Impala and ECMO device, we can intervene in the patient with severe LV dysfunction of 15 to 20%. Left main PCI outcomes match CABG as shown in the Excel trial. We are not guessing anymore. We are seeing it, measuring it, and delivering it. What about the complex cases? CTO PCI, chronic total occlusion PCI, all success rate is almost 90%. Multivessel FFR guided PCI competes with the CABG. If the anatomy is good in diabetic patient, PCI is safe and effective. Post CABG patients, PCI saves them from the redo surgery. So we are not afraid of complexity anymore, because we now have a tools, imaging, as well as the data. But definitely CABG has its place, but let me honest about it means what for the patient. It is invasive with some neurocognitive impact, prolonged recovery, graft failure over time. So today's patient want minimally invasive options, wants less downtime, less risk, and repeatable solutions, and PCI exactly delivers. If you talk about the OMT only, after the OMT, there are residual angina patients, even on 4 anti-anginal drugs, statins, antiplatelets, lifestyle changes, patients still feel some chest pain, breathless, still afraid. So PCI can offer them immediate relief. Stent doesn't just open a vessel, it opens your life. That means something to the patient, to their family, and to us as a healer. This is a comparison of trials. I'm not going into the detail of these trials. In India, we are seeing the CAD in the young, in the productive, in the rising stars of our country. They don't have time to wait. They need relief now, not in 6 months. And we are equipped to deliver even in the left main, bifurcation lesion, small vessel disease. So we have gone from can we do this to we are doing it daily. This is a female, 56-year female, hypertensive, diabetic, hypothyroidism, obese, left frozen shoulder. This is the coronary angiogram. And you can see in this, there is a left circumflex disease, there is a disease in the ramus, and you can see some disease in the LAD also. In this epicranial view, you can see the proximal and the mid LAD has some disease. Right coronary artery is also having some disease, proximally as well as in the PDA. So what is the angio report? So angiogram shows proximal to mid 80% lesion in the LAD, ramus is 50 to 60%, circumflex has 2 tandem lesions, RCA, proximal 70, PDA 90. So what is the management? You can go for the OMT, PTCA single vessel, or PTCA multi-vessel, or CABG. So answer should be in the physiological guided. Do an FFR. We did an FFR in this patient. FFR of LAD after adenosine is 0.63, which is very significant. But the FFR of other vessel is negative, 0.86 in the circumflex. In the RCA, it's 0.92. So we just stented the LAD and the patient did well after the LAD angioplasty. So where PCI beats both OMT and CABG? In acute coronary syndrome, CABG is not feasible. FFR positive lesions, PCI is precise and durable. In ISR, focal graft disease, PCI is less invasive than redo CABG. DCBs or polymer-free stents, an answer for the HBR patients. Selected left main bifurcation lesions is comparable to CABG with faster recovery. Acknowledging the surgical strengths, diffuse triple vessel disease in diabetics, CABG is superior. Hybrid revascularization combined strength. Heart team approach delivers the best patient outcome. So closing remarks, in 2025, PCI delivers speed in ACS, precision in chronic coronary artery disease, innovative for the complex anatomy and HBR patients, less invasive, faster recovery. Medical therapy alone can't reopen the blocked arteries, and CABG can't match our speed, patient comfort, or adaptability. So future belongs to intervention. It is not an option. It is the answer in 2025 because it is safe, precise, patient-friendly, and future-ready. Thank you.
Thank you. Thank you, Dr. Naveen. Let's see what Dr. G.K. Mani has to say.
Okay.
While I wait for my slides, I must compliment Naveen for having set the stage. That's why I made my son into a cardiologist. He's a professor of cardiology in Kansas University, and he's an interventional cardiologist. So I'm biased towards PCI, and I have to speak on CABG. Look at my dilemma. Nevertheless, I've been doing these operations, Dr. Chopra knows this, for 45 years, and I think still it has a role. There was a misprint in the program that I was in Apollo Hospital. Yes, I was in Apollo, now I am in Max. Medical management, of course, interventional treatment. The objectives are improve myocardial ischemia, hypoxia, control risk factors, treat cardiac dysfunction, and maintain good perfusion for a long time. Clinical indication is the main thing. Informed consent, patient-centered care, and shared decision-making is what is required today. Not what one modality is better than the other. Factors to be considered by the heart team, the coronary anatomy, the comorbidities, procedural factors, regional factors, access sites for PCI, surgical risk, PCI risk, etc. Patient factors, unstable presentations, adherence to double antiplatelet therapy, patient preferences. Patient preference may be overruled or followed only after objective decision by the heart team. Just by saying that मेरे को surgery नहीं कराना is not an indication for PCI. STEMI. Naveen spoke a lot about STEMI. Yes, less than 12 hours early revascularization is important. PCI is class 1 indication for culprit artery revascularization. STEMI with cardiogenic shock, PCI is equivalent to CABG class 1. STEMI with mechanical complications, ventricular septal rupture, mitral insufficiency, free wall rupture, CABG is class 1. Sorry, Naveen. STEMI, unsuccessful PCI and a large area of myocardium is again, doesn't have enough evidence to be class 1, it's class 2A. So if we have a STEMI, what do we do? If the symptom onset is less than 12 hours, then we go for PCI. And if PCI is not possible, then you go for, and if the large area of myocardium is at risk, we go for bypass. If the symptom onset is more than 12 hours, if there is cardiogenic shock, is PCI feasible? Yes, go for PCI. If PCI is not feasible, go for bypass. Ongoing ischemia, heart failure, again PCI is the answer. Symptom onset between 12 to 24 hours, PCI again. Totally infarct-related artery, more than 24 hours, no symptoms, no PCI, nothing at all. Remote revascularization after successful PCI of a STEMI infarct artery. Complex multivessel disease in other arteries. Bypass surgery is still the option. 2A. Decision to be made by the heart team after evaluation of symptoms of angina, ECG abnormality, large area of myocardium is ischemic on PET-CT or thallium. The purpose of bypass surgery is that it would reduce the risk of future cardiac events. I mean, we have now colchicine available, but bypass surgery proves even better. Risk of stroke with bypass surgery is relatively less, with off pump surgery. So most of the articles which are quoted in the literature are on pump surgery, which is more common in the West. Stable ischemic heart disease, SIHD. Left ventricular dysfunction, class 1 indication when ejection fraction is 35% and low. In 35 to 50%, yes, you have class 2A. Left main coronary artery disease, is that still a debate, Naveen? In single vessel, in stable ischemic heart disease, it's class 1. In stable ischemic heart disease, it's only class 2A PCI. Multivessel coronary artery disease with or without proximal artery LAD lesion is class 2B. I used to lobby for proximal LADs being class 1, but it is not. PCI in this situation offers no proven survival benefit. Stable ischemic heart disease, as you can see, this is a very complex algorithm, but I would just suffice to say, if a patient is having significant left main disease and the complex anatomy, and if PCI is not possible, CABG is again coming to class 1. PCI is at the best at 2A in most of the places. And as far as the heart team discussion, it's very important in this stable ischemic heart disease. And yes, GDMT has a role with or without PCI. CABG still has a role if ejection fraction is low. So, revascularization strategy as what is said in ACC-AHA guidelines 2021, significant left main plus high complexity coronary anatomy, bypass surgery class 1, diabetic patient with multivessel disease, LAD involvement, bypass surgery class 1, multivessel coronary artery disease, complex coronary anatomy, syntax more than 33, CABG class 2A, previous CABG in a redo situation with LAD involvement, still redo bypass surgery is class 2A. I do agree that if the internal mammary artery is not used, these used to be more often present, but now most of us using internal mammary artery one way or the other, or both internal mammary arteries, this is much less. Previous coronary artery bypass surgery and complex coronary anatomy not suitable for PCI. PCI should be the first, otherwise it's bypass surgery. Left main, I'll talk to you in a little bit more. I mean, task force is important, which involves interventional cardiologists, cardiac surgeons, cardiologists, statisticians. And basically, it is the decision of the heart team. Both PCI and CABG are equal. CABG versus PCI in left main study was 11,137 patients quoted in European Heart Journal 23. Median follow-up 44.7 years, outcome favoring CABG. They live 3.6 years longer, median survival in diabetics undergoing CABG. So the balance is tilting towards the bypass surgery. When you're talking about these factors, along with left main, reduced ejection fraction, diabetic patient, contraindication to dual antiplatelet, recurrent diffuse instant restenosis, distal bifurcation lesions, presence of multivessel disease, all association with left main, high anatomy complexity, syntax more than 33, occluded dominant right coronary artery, severe calcific coronary artery surgery, no need for a concomitant aortic cardiac surgery, which includes aortic stenosis, mitral regurgitation. All that is indication for bypass surgery. Again, the Swede Heart Registry, which is quoted in European Heart Journal, there was a follow-up for 4.7 years, outcome favoring CABG. These are the various trials that were studied, and this is the summary of this 4,595 patients, 5 randomized trials, 30 days, yes, PCI scores over, But later on, it is CABG which stays on to. Comparing CABG and PCI across the globe based on current regional registry evidence, evaluate the impact of CABG or PCI in different regions of the world. And this is it's a busy kind of a slide. As you can see, in all these countries from where these meta-analysis has been done, it's all favoring CABG when compared to PCI in triple vessel disease along with left main. This is a paper from China about 2 months ago in Current Problems in Surgery 2025. 8 studies included 7,100 patients. Everything is better with bypass surgery. Beating heart surgery is slightly the strategy that we use. As you can see, the operation goes on the left side while I talk about why we did beating heart surgery.
Sir, you'll have to wind up the talk. You'll have to wind up your talk. Yeah. He can continue? Okay.
Sorry. It was realized that morbidity was more because of the machine and not because of the surgical technique. So we started doing beating heart. And as you can see on the next picture is the arterial grafting that we do, where we can do the coronary artery bypass without touching the aorta. The left internal mammary artery is put onto the LAD and the diagonal, and the right internal mammary artery is switched on to the LAD, and it can revascularize the whole heart. The take-home message, ladies and gentlemen, decision about bypass surgery or PCI should be based on ability to complete revascularization, weighing short-term risk of death and stroke. Stroke, again, only in the West, we don't have strokes. With CABG, with the long-term benefit of reducing the risk of repeat revascularization. So we have to weigh this risk. Risk of stroke is relatively less with off-pump strategy and aorta no touch. Patient preference should not be considered as the main thing. A heart-term decision should supervene. Thank you very much.
So shall we have both the speakers on the dais? How does it work?
Yeah, all 3 of them on the dais and questions from the audience.
Okay, all 3 of them on the dais, Dr. Naveen, Dr. Mani and Dr. Rajiv. Yeah.
Questions from the audience, and what should be the strategy in 2025?
I'll wrap up and
That should be take over.
yeah, I'll take it.
We have a lot of time.
Okay.
Don't worry about it.
Okay. I was. So we'll have questions from the panelists, then we'll have the questions from the floor also. No. Yeah. Okay. Any question from the panelists? Yes.
Sir, thank you for a wonderful enlightening lecture. CABG versus PCA versus medical management, everything, sir. Sir, I just was going through the Mayo Clinic paper. I would like to take your opinion regarding that new prevention of mRNA technique based risk stratification or genetic slicing thing. Is it in still a theoretical stage or anything?
You are talking about mRNA based
Gene stratification.
The therapies which are
Yes, sir.
available,
Yes,
they
sir.
are still experimental by and large. The usage of newer anti lipids drugs like inclisiran, which is also based on similar concept, is now well established. We have in the CSI, which is going to be held here in December, we have submitted a paper of 80 cases in whom we have given inclisiran, and we have the results. These were all patients who were not able to achieve LDL of 45 or 40 as they had multiple events, but they were on statins, ezetimibe, as well as bempedoic acid. These patients received inclisiran, and we were able to achieve phenomenal LDLs like 3, 6, 9. And now it is documented that low LDL is not a non-physiological phenomena. Patients can live with that. At 3 months and at 6 months, the LDL tends to come up, but it is usually in 30-40 range. So these were patients who were either intolerant to statins or who were not able to achieve the targets with statins. So this is something which has emerged now, and the trials have, the Orion trials, it is well established now. The usage of the silent mRNA inhibitors is well established and is going to increase in the future.
And
Yeah, can I make a comment here, please? Yeah, I have almost every patient with LDL of less than 55 on multiple therapies. If we don't achieve with a combination of high dose of statin plus bempedoic acid plus etrasimod, I go to inoscleran. And almost always, all my patients have less than 55, as low as just 30, especially those who have undergone bypass, who had multiple stents, patient who had recurrent event even after having all these interventions.
Absolutely.
That's one. Number two, another thing, diabetic patients with multivessel disease, patients with having multiple blockage in multiple arteries, LED blocked at 2 points, 3 points, 80% at one point, say proximal 80%, distal 70%, RCA again 80%, circumflex 90%. I think these are patients, especially diabetics, for bypass surgery, not for multivessel PCA. Though the trend is for PCA, many of my patients do ask me what we should undergo for. They have had opinions from different cardiologists, and they are all willing for doing multiple PCIs. But I think in the nutshell, if they have diffuse disease, multiple obstructions in multiple arteries, case probably for, especially if they have a low ejection fraction as well.
Naveen, what is your opinion?
Before Naveen says, let me speak.
Multivessel disease, diffuse disease, severe LV dysfunction. If you talk about the science, yes, CABG scores over PCI.
Thank you.
But nowadays we can do a physiologically guided PCI. We can do an FFR, IFR. If the FFR is significant less than 0.8, we can do just a simple angioplasty of that area and keep him on optimal medical therapy. This is again another strategy. But if you ask me one thing, that CABG scores over PCI in this case.
Well, I think to prevent future cardiac events, I mean, I'm not saying that PCI is not the answer. PCI is probably the answer. It is very good for a 100-meter dash, but it's not good for the 5-mile run. So I think if you talk about longevity of relief and life expectancy, definitely bypass surgery.
Exactly. As Dr. Mani says, just a few weeks back, I had a patient, I did the angiogram. There was severe triple vessel disease. He came from some remote village in Purnia, which is Papu Yadav's constituency. My colleague, my junior consultant said, let's stent all of them. They were all easily stentable. I told him, this guy is going to go back there. He's not going to take therapy. He's probably not going to take statins. He's probably not going to take regular antiplatelets. So CABG in this case would be a better option for him. Even though they were stentable vessels, the patient underwent CABG and is doing well. So it is the concept should be what is best for the patient. It is not what the patient wants. There is a difference between the two statements. What the patient wants is easily what the cardiologist convinces him. The best and the most important practice that we do at our hospital is what is best for the patient. So if we feel like this example, that the patient would probably best benefit by surgery, even if he does not continue taking appropriate medications, the possibility, as Dr. Mani says, of him having longevity as well as graft survival after say 10 years, 15 years is more with bypass surgery than with putting multiple stents and not taking medicines. So this is in nutshell what we should be advocating.
But the bypass should be done by a qualified,
experienced, bypass is done by all qualified surgeons.
experienced surgeons who put arterial grafts. So there are surgeons who are putting arterial grafts on an LED which is less than 1.5 millimeter diffusely disease, and they say, I will do the CABG of this patient.
We are talking about ethical practice.
Yes, yes.
Whether it is cardiology or cardiac surgery.
Exactly.
If
Okay,
it is
we have
not
a-
ethical, then we
we
cannot
have a-
talk
we have a
about it.
question
I think,
from the floor.
there should
Yes.
not be any fight. It's a very clear debate. I think the answer is very rightly given that when we see a patient, we should not be only guideline directed. It should be consciousness directed. And I think as Rajiv just mentioned, that I convinced the patient, I knew that he is not going to take medicines. He was the ideal candidate for bypass. So why not? I think when we know that the outcome is better, the survival is better, intervention is one modality, there is no doubt about it. But I think it's a consciousness-based approach is the best approach rather than only guidelines. Because guidelines are not guidelines. They are the support lines. The message should go in very clearly. How we individualize our patient, and motivation should be in the right direction. Because patient is a patient. He will believe you. He will trust you. So if you speak from heart and from a consciousness, I'm sure we'll do the right thing.
Absolutely. Very well put.
It's a hard team approach.
Yeah, hard team.
That's correct. Yes. Any other questions from the floor or panelists?
Now, where you will prefer
there's a
the
fight
drug-
is going on between the
Probably this will be
physician,
the
cardiologist and the surgeon. As far as microvascular angina is concerned, I think Rajiv scores over. And how to manage and what are the disadvantages? If you don't manage, you get angina frequently despite all the medicines, which is quite common. So what do you say? What should be treatment and what are
Sir,
the
now
harms?
the microvascular angina term is almost given up. What we have is MINOCA and INOCA. INOCA is infarction with normal coronaries, and MINOCA is ischemia with normal coronaries. So this indicates that there is dysfunction in the microvasculature. The management includes lifestyle and various drugs like nicorandil, like diltiazem, like statins. Not much role of beta blockers, not much role, but the role of lifestyle modification drugs, which is now coming, the role of GLP, maybe SGLT2. These are all being studied in various trials now. And probably these will become a part of guidelines in the near future.
many of these patients of Minoca or Inoca have myocardial bridging also. We have seen many patients undergoing angiography and they have myocardial bridging and they have ECG changes, they have suffered from ischemic changes. So myocardial bridging is also...
Myocardial bridge, sir, is a physiological phenomena. It is usually because of the muscle.
Yeah, entrapping the
compressing
artery, I know that.
Actually, myocardial bridge, we have seen patients getting stented in because of some atherosclerosis and it is usually a disaster.
Should not.
Last question I'll ask you. The drug-coated balloons, they are more expensive than the drug-coated eluting stents.
Yes, sir.
So why they are preferred, balloons over the stents? What is the advantage?
So DCB has the advantage, especially in the patient who is having high bleeding risk, HBR patient. Suppose there is a patient presented with the ACS and there is a bleeding going on, or the past history of GI bleed is there. In such patients, in instant restenosis, if you offer another stent, then the chances of restenosis increase. So if ISR is there, just do a DCB, but it should be done for 60 seconds, 90 seconds with paclitaxel or sirolimus coated stents. But it is now recommended as a class 1 indication for ISR. A small vessel disease where you cannot do anything, we cannot put stent, you cannot do a bypass. In such cases, DCB scores over the CABG or the medical management. So these are the areas where DCB scores over CABG or stent, that is small vessel disease, ISR, high bleeding risk patients, or in some patients, ethically indicated in all these cases. But yes, you can do sometime, we can do angioplasty stent in the one vessel and the DCB in another vessel to decrease the load of the metal in the patients. But these are the three
I
only
think
class 1
the
indications.
use of DCB is increasing. It is increasing, especially as Naveen pointed out, in younger individuals. We don't want to give metal. We have been using, in fact, in acute coronary syndromes, we have been using. Yeah. But the most important thing, even though the guidelines are equivocal on this, is to evaluate by OCT. We should be able to see inside that we have achieved optimal result, we can actually see the drug-coated particles against the vessel. So first is achieving a good lumen, which will require a cutting balloon or a scoring balloon, and then subsequently putting a DCB and achieving a good lumen, which preferably should be imaged, so that we are sure that what we have done is lasting. Now we have been doing DCB for almost 2 years, 2.5, 3 years, and we are getting restenosis in DCB.
And even
So it
I
is
did
not a foolproof method.
I did DCBs in acute MI also. There are 15 patients of mine in acute MI, young
it is being
patients.
done.
Yeah.
Let's go. Any other questions from the floor?
Follow-up is, history-wise only, and there are 2 patients we did a check angio and everything is fine.
Any question?
In situations of redo stenting, what do you recommend? Redo stenting if a stent is being blocked.
And if there is an instant restenosis, DCP is the answer. 1 time, 2 times, but after that, CABG is the only answer. Up to 2 times you can do but it should be done very precisely. As Dr. Passey said, do it with image guidance, prepare the bed very well, and then do the DCB. DCB is the answer.
We can actually see in restent stenosis what is the etiopathogenesis using the imaging like OCT, whether it is neoatherosclerosis or whether it is, we can actually image everything. And majority of the cases we can predict that this patient will have restenosis again or will not have restenosis again. So it is a very scientific approach which can be done in these cases.
I think patients who had restenosis, probably there is a role for colchicine also, apart from the other drugs.
Yes, colchicine plus very strict lipid lowering, all these
That's
drugs.
less than LDL, less than 40 probably.
Yes, sir.
I think if there are no questions, I'll try to wind up. Medical management is the baseline. All patients with coronary disease should have medical management, standard guideline directed medical management. And following that, if the patient has coronary disease which is significant, the decision to make whether the patient should go for a PCI-based strategy or the surgical-based strategy possibly depends upon the number of blockages, the length of the blockages, the complexity of the blockages, and the associated problems the patient has. Suppose the patient is diabetic, he's got triple vessel disease, left main disease, calcified vessels, it is better to go in for surgery. Otherwise, if he has discrete lesions, young guy, it is better to go in for PCI-based strategies. In case of restenosis and small vessels, long vessels, the role of drug-eluting balloon is coming up, cutting balloon, followed by drug-eluting balloon with assist by the IVUS or the OCT, whatever is available in the institute. And this is coming up. And I think in the recent coming years, drug-eluting balloons are going to be like stents, and they may partially replace stents as well. Would you like to make the final?
Excellent work done by the 3 speakers. Excellent. Ultimately, it depends on the patient, how much to convince the patient. Ultimately, the decision depends upon the patient.
No, I have a point to say. This convincing the patient, if the patient goes to surgeon tends to convince. If the patient goes to PCI guy, the PCI type guy tends to convince. So I think what is important is as Sir had said, make a conscience-based decision, what is good for the patient, and try to advise him the best. I think that's what is important. Thank you.
Thank you, sirs. It
There's
was an
one more
excellent
indication
session.
one last comment. There's one indication for bypass versus PCI when patient is not able to afford the cost of multiple stents, because multiple stents many times cost more than 4 or 5 lakhs.
So Modi ji has ensured
Okay.
that stents will not cost more.
That's
Modi ji is there. You don't have to worry about that.
Okay then.
So, towards the end, I would request all the speakers, chairpersons, and panelists to come on the right side of the dais for felicitation. We finished the session on time, so I think a big round of applause for all the speakers.
पहले आप डॉक्टर छाबड़ा उधर पकड़ा उनको, उधर दो डॉक्टर उमर।
जा हाँ सर का ही है. Thank you, everybody. Thank you, Hansa. Thank you, Dr. Simi. Perfectly finishing on time. In fact, less than even 2 minutes before 12:30.